Okay, hello, good morning, everyone. So we had a new grand rounds today. We had a very special guest today. It's actually an international speaker, Dr. Suvankar Pal. So Dr. Paul is a neurologist with academic and clinical interest in neurodegenerative disorders, and is a clinical lead for the UK National CJD Research and Surveillance Unit at the University of Edinburgh in UK. This group has been providing a comprehensive surveillance of CJD in the United Kingdom since 1990 and has been a leader in international surveillance. Dr. Paul is a very accomplished researcher and very a fortune for us to have him to speak to us. So welcome, Dr. Paul.
Brilliant. Thank you very much, Sergio, and thank you for the very kind introduction and obviously the invitation to speak to you all as well. So it's good afternoon from here. It's 2 o'clock in the afternoon in Edinburgh. I think it's just gone 9 where you are in the morning. What I was going to do today is give you a clinical update, really a focus on the clinical features of prion diseases, and just to orientate ourselves. I don't have any financial or commercial disclosures. We'll give a quick overview of human prion disorders, a little bit about the work that we do here at the UK CJD Surveillance Unit in Edinburgh. I'll talk about the clinical features and investigation results of sporadic CJD, which is by far and away the commonest form of CJD, and adult neurologists will see this, or the differential diagnosis of this, but also give an overview of other prion disorders, particularly inherited forms of prion disease, variant CJD, which has gained a huge amount of scientific attention and has led to surveillance in the United Kingdom, and other forms of acquired prion disease, which are important to understand and be aware of. I'll talk a little bit about symptomatic management of these challenging patients, and what really is active in CJD prion clinical surveillance now in 2022 in terms of recent cases of variant CJD that have been reported, zoonotic concerns, and I'll end with talking about potentials for treatments and the need for ongoing clinical trials. So firstly, just to start with terminology, these can all be used variably and interchangeably in the literature. Creutzfeldt-Jakob disease, named after the German neurologist that first described the syndromic condition, Creutzfeldt and Jakob, prion disorders, and transmissible spongiform encephalopathies, TSEs. And these really describe a group of neurodegenerative disorders that are uniformly progressive and unfortunately untreatable. What's interesting about these disorders is they can affect humans and animals, and a key feature for public health purposes is that these disorders are potentially transmissible. So we talked about the definition of prion. The prion hypothesis is based around a conformational change in a host-encoded protein, the prion protein. And there's a unique mechanism of disease where there's post-translational conversion of prion protein by conversion of the cellular prion protein to self-propagating aggregation prone multimeric assemblies of PRP-SC, the scrapie form. And it's direct protein-to-protein spread of disease that is unique in its biology, in addition to its transmissibility. I mentioned before that the commonest form of CJD is sporadic CJD, which accounts for 85% of cases that we see. There are rare but very important forms of acquired disease, so variant CJD, transmission from medical and surgical instruments, and inherited prion diseases. The prion protein gene is important to understand. There's a polymorphism at codon 129 of this gene, and in the normal UK population, individuals are either methionine homozygote, methionine-valine heterozygote, or valine homozygote, and this can lead to changes in the way that clinical presentations occur. There are also disease-causing mutations and expansions in the gene, which can lead to autosomal dominant forms of inherited prion disease. And there will be eponymous syndromes that you'll have heard of, Gerstmann-Strauss-Schwanker disease, which is due to a point mutation of the P102L, and fatal familial insomnia, which is due to a D178N mutation. So these are important to understand. I'll come on to touch a couple of cases. I mentioned about animal prion disorders. Scrapie was first described in the 18th century, affecting sheep and goats. And beyond that time, prion disorders have been understood to affect a variety of different animals. So I'll go through some of these in detail later. Chronic wasting disease is something that's of topical interest in the States at the moment. Bovine spongiform encephalopathy, BSC, is obviously something that gained significant interest in the United Kingdom in the 1980s and 90s. And then camel prion disease is a new form of disease that's been reported in the last few years, but has global significance potentially. And the unit that I'm based in Edinburgh was really formed following identification of BSC in cattle in the United Kingdom in the late 1980s. And there was a report there from the government of the UK recommending close monitoring of cJD in the human population. And so our unit was funded by the UK Department of Health and Social Care and established in 1990. And our primary aim was to identify changes in the characteristics of cJD which might be linked to BSC. Is there a requirement for ongoing cJD surveillance right now? So this is a helpful review article that we published in Nature Reviews Neurology last summer. The reference is here. But really, there are a number of international surveillance programs that have been established in subsequent years, and all of the units really focus on monitoring the characteristics of all forms of human prion disease to identify trends in incidence rates, study risk factors for disease, and also now branching out into clinical care to improve the quality of care for people living with cJD and to promote other research opportunities. And this schematic diagram summarizes what many surveillance centers might do. So they might be regional or national centers that provide either in-person assessments of individuals with suspected prion disease or a comprehensive review of the case records, interviews of the patient and their relatives, and a structured clinical examination. It's important when going through the history to think about iatrogenic exposures, family history that might point to an autosomal dominant inheritance, and then occupational and zoonotic exposure. I'll come on to touch about some of these areas. And the one thing that has developed in human prion disease research over the years is an improvement in clinical diagnostics with MR imaging, CSF analysis, and prion protein gene sequencing, which I'll come on to talk about. And then in many centres, there'll be ongoing referrals for clinical care, enrolment into trials, genetic counselling and predictive testing for prion protein mutations, and importantly, public health actions that might need to be taken, for example, quarantining of instruments and blood products and contact tracing of individuals who might be at risk. So in the UK, we have research registrars, young trainee neurologists who travel up and down the country by plane and train and assess individuals locally in their local centres. We also, during COVID, moved towards a degree of telehealth-based assessments and interviews of families and video assessments of clinical examination features. And we receive referrals from neurologists, general physicians, geriatricians, a small minority of individuals who are assessed in the outpatient department from cognitive disorders clinics, some individuals who present with a really rapid presentation that's often mistaken as a stroke from stroke units, some individuals increasingly who present with very relentless neurological decline and end up intubated on the intensive care unit, from psychiatrists and from other sources. We also receive referrals from neuropathologists where people were not sure what the diagnosis was in life, and then an autopsy was suggestive of cJD, and also a review of death certificates in the UK. And if anyone was reported to have cJD that we were unaware of, we will assess them after life by interviewing their family and going through risk factors. So since we were established in 1990, we've received referrals, and what we try and do is classify cases according to well-established international European diagnostic criteria. And the summary of the cases that we've classified are in this table here. We assess probably twice as many that are classified as non-cases in the end. And you can see that the majority of individuals have sporadic cJD. There are individuals with iatrogenic, genetic, and you'll see the numbers of variant cJD are 178 since this disorder was first described. We have a linked care team that have two highly specialised nurses that are funded by NHS England, and they have a national UK remit with their aim of optimising the care of people suffering with cJD and liaising with families and supporting care planning. So let's move on now to the clinical features of sporadic CJD, the commonest form of human prion disease that we see. I think the characteristics here to remember a rapidly progressive dementia is the hallmark feature. Neuropsychiatric symptoms can be common, and then obviously if you think about cognitive domains that may be affected, whilst everything occurs very rapidly, we try and drill into changes in memory, language, behavior, visuospatial change. Individuals often have paranoia, agitation, hallucinations. And it's this combination of cognitive and motor features which is often the telltale signs. So ataxia is common, myoclonus is common, and rigidity is common. And the end stages of all forms of human prion disease are very similar in that individuals are often restricted to bed, mute with significant aphasia, and reduced or no awareness, and often with quite florid myoclonus. The median age of onset is in the late 60s, but there has been a range, and the youngest individual we've reported on has been 15, and then individuals, we don't fully understand why the incidence tails off in people's 80s and 90s, but there are individuals increasingly reported in these older age groups. And the median duration of illness is only 4 months. So you can see that the diagnostic process often leads to a palliative phase and symptom control and death very quickly. It's all a very rapid course, and really stands out amongst other neurological disorders for its rapidity. So let's talk through a typical case. So a typical case of sporadic CJD with methionine homozygosity at codon 129 of the Prion protein gene. So this is a 63-year-old adult who presented with acute onset expressive speech difficulties, and then quite rapidly became disorientated, impaired attention, had short-term memory problems, and then gait impairment over several weeks. There was also associated abnormal behavior with outbursts of aggression. If you remember, it's important to go through the family history, screen for occupational hazards, and this individual had nothing really of note in the past history. Examination confirmed that they were significantly affected cognitively with mixed expressive and receptive speech difficulties and quite marked disorientation. And a neurological motor examination identified pyramidal and cerebellar signs as well as dyspraxia. And I want to highlight the MRI scan here because actually individuals have access to MR imaging much more readily now than even 5 or 10 years ago, and even in satellite centers away from the major neuroscience centers. And it's often the MRI scan that will trigger the consideration of sporadic CJD in the early stages of illness. And on the scan here, you can see typical appearances of multifocal cortical ribboning, the parietal, occipital, and interhemispheric cortex. The individual went on to have an EEG, which demonstrated periodic sharp wave complex as one of the other hallmark features seen in the investigations. And CSF examination, which is important in individuals, I guess, firstly, to exclude treatable reversible causes of infectious inflammatory disorders, encephalitides, but then also to look specifically at biomarkers for Prion disease. So 1433, which is a biomarker for neurodegenerative change generally, and then the real-time quick, which is a protein misfolding assay. So both of these tests were positive. S100B, which is another marker of neurodegeneration, was elevated. So the combination of MRI, EEG, and CSF were all supportive, and the individual continued to progress and became bedbound and mute with myoclonus and died 102 days after symptom onset, had a post-mortem and autopsy confirmed sporadic CJD. And so really that case highlights a number of features of the European CJD surveillance network diagnostic criteria which have been adopted by a number of nations globally. You can have different levels of classification. So essentially a definite diagnosis is made on the basis of autopsy findings. But a probable diagnosis, which essentially equates to a sensitivity and specificity in the high 90s, is a combination of the clinical features, so rapidly progressive cognitive impairment, and then a constellation of other motor features, either 2 of myoclonus, visual or cerebellar problems, pyramidal or extrapyramidal features, and then ultimately akinetic mutism. And then thinking about the investigation results that are associated with that. So changes in MR imaging, which I'll come on to talk about in more detail, changes on the RT-QuIC assay, and changes on EEG. So really it's a combination of clinical history, examination findings, and these test results that lead to a hierarchy of probable, possible, or definite diagnosis. And we evaluated, this is a publication from just a few months ago that we, in JAMA Network Open, where we really looked at the sensitivity and specificity of these diagnostic criteria in the UK, but also in Germany, Italy, and France, from autopsy confirmed cases as the gold standard. And really from this table, I just wanted to demonstrate that some of the features that I mentioned, that the disease affects men and women equally, and the mean age of onset is in the late 60s. And the clinical features really that come up here are a rapid cognitive decline and myoclonus, are kind of the commonest, and cerebellar features. And then pyramidal, extrapyramidal, and akinetic mutism occur at variable stages of the disorder. But of course, there are other disorders that can present this way with rapid cognitive decline and other features as well. So important to think about differential diagnosis and exclusion of other causes as part of the diagnostic workup. And I'll touch on this briefly in terms of other common differential diagnoses. But the criteria were revised recently to include the changes of cortical ribboning, particularly isolated cortical ribboning on MR imaging, and CSF RT-QuIC status. And both of these have significantly increased the sensitivity of diagnosis in life. So the clinical features are highlighted here. Rapid cognitive decline, I mentioned, myoclonus, visual. These are the sort of things that we see in cases. And what about differential diagnoses in the non-cases, that the individuals where CJD was suspected in life? Well, you'll be familiar with this from your caseload. So really, other neurodegenerative disorders can, in later stages, look like CJD in advanced illness. You can have rapid forms of dementia with Lewy bodies, rapid forms of Alzheimer's, or even Alzheimer's in the later stages following a typical trajectory. You can have neuroinflammatory disorders, metabolic disturbance, seizures. There are certain infectious causes that are reversible. So these were the postmortem autopsy confirmed diagnoses that we identified from the 4 nations where we studied autopsies in individuals where CJD was considered in life. And this tallies really with causes of rapid progressive dementia from other cross-sectional studies performed and longitudinal studies performed in cohorts across the world. So non-prion neurodegenerative dementias tend to be the commonest differential of CJD, and then followed by autoimmune disorders, increasingly the autoimmune encephalitis and infections. So Alzheimer's, frontotemporal dementia, dementia with Lewy bodies. Obviously, mixed pathology is common, and we've investigated in case series here in the UK. Individuals, particularly with increasing age, can have mixtures of amyloid tau, Lewy body deposition, TDP43 pathology. So they can be quite challenging cases. What about investigation results? Well, I mentioned that we look at EEG, MRI, 1433, and real-time QuIC. So these vary in accessibility in neuroscience centers, and also vary in terms of sensitivity and specificity. So EEG is probably widely available in neuroscience centers, but really lacks specificity until people reach the advanced stages of disease. And so EEG is something that may be helpful. It's non-invasive. So in individuals where CSF examination or an MR, particularly because someone might have significant myoclonus and it's unable to tolerate lying still in the scanner, it might be helpful. But actually, we still try and recommend MR and CSF, because you can see the sensitivity and specificity so much higher. For MR imaging, when you look at cortical ribboning, basal ganglia signal change, either alone or combined, there's a high degree of specificity for these changes, and for the combination of cortical ribboning and basal ganglia signal change, a high degree of sensitivity. 1433 is a non-specific marker of neurodegeneration, and elevated levels in CSF really do not discriminate between different neurodegenerative disorders. But the CSF RT-QuIC is highly sensitive and in certain hands, in certain laboratories, 100% specific. So a false positive RT-QuIC has been reported in individual cases in the literature, but is highly, highly unusual. So the EEG changes typical triphasic periodic complexes. The EEG tends to evolve during life and is often helpful in the more advanced stages of disease. So in sporadic CJD, MR brain imaging, when a patient is able to tolerate this, is helpful, particularly T1 images, flare and diffusion weighted imaging. And what we tend to see are changes in the basal ganglia, the caudate and putamen, and also the changes in the cortex. You saw the previous imaging with cortical ribboning, but also identified here on images B and C. CSF examination. So the real-time QuIC, there are many labs now internationally that have the expertise to deliver this. The real-time quaking-induced conversion assay is a modified multi-well plate-based amplification technology which can amplify the misfolded prion protein, and it couples to a fluorescent readout. And so you can see here on the right, when you compare with control cases with other neurodegenerative disorders like Alzheimer's, you get a takeoff in readout with a positive control in red, the sporadic CJD case number 1 in green, and the orange as well, and the control and unseeded CSF assays having a flat line here. I mentioned this really has a very high degree of sensitivity and specificity for sporadic CJD. It has been a game changer really in the diagnostic workup of individuals with this disease. We don't know a huge amount about longitudinal change in RT-QuIC because obviously people don't have longitudinal lumbar punctures, spinal taps, but we do know that it is sensitive and specific even in the earlier phases of symptoms. And then ultimately the gold standard diagnosis is still based on autopsy and neuropathology, very rarely brain biopsy. Increasingly centers are avoiding this if possible, partly because of the public health implications of instruments, but also because the sensitivity and specificity of the diagnostic test is improving so much. The autopsy rate is declining and brain biopsy rate is declining. But what you see is spongiform change, vacuolosis, and then when you stain, there are various antibodies to the prion protein, you get aggregation of the prion protein, and really affects all brain areas. So here's another reference to a helpful review article published as part of an international consortium, really looking at biomarkers and diagnostic guidelines for sporadic CJD, published last spring in Lancet Neurology. So do have a look at that for more information about these various tests that are available. I think I just on this slide wanted to highlight the importance of excluding other differentials. So one of the major differential diagnoses of sporadic CJD is inherited CJD, inherited prion disease. And so one of the exclusions is to screen the prion protein gene and try and exclude an inherited prion disease. Obviously other forms of CJD are also differential. So it's important to screen for iatrogenic risk factors and to consider variant CJD. So the other more advanced test that we can do on autopsy material is to look at molecular typing of abnormal prion proteins. So these are protease resistant proteins, PRPSC, and when you treat it with proteinase K and then run a Western blot, you can see that there's electrophoretic mobility that differs between the different types of prion disease. So sporadic CJD MM1, we are homozygous for methionine at codon 129, has a typical type 1 classification pattern. Sporadic CJD VV2 has a separate pattern, and variant CJD has a different glycosylation pattern after treatment with proteinase K and running on the electrophoretic gel. And you can see that the variant CJD signature looks identical to that of BSC, and this was one of the features that led to the identification that BSC and variant CJD were directly linked causally. What about the influence of codon 129 genotype on the way that people present with this condition? Well, One of the things that it influences disease duration and survival. So I talked about that typical case. Individuals who are codon 129 at tend to have a shorter duration of survival, MV and VV longer. And then you can classify it by the glycotype that I mentioned, and that can look at survival in more granular detail. The clinical features of these individuals, because they're surviving longer, cerebellar features tend to be longer and tend to be more apparent in MV and VV heterozygotes than in methionine homozygotes. So sometimes even just having the codon 129 status helps with prognostication of these individuals. So just to highlight that point, a case here of a valine homozygote type 2 after treatment with proteinase K subtype of sporadic cJD. So this is a 74-year-old female, slightly older individual, gradual onset and progressive gait imbalance over 3 months with preserved cognition initially, and then further deterioration with falls and upper limb clumsiness, a really progressive cerebellar syndrome. And then after that period of maybe 4 to 6 months, developing behavioral changes and short-term memory impairment, and was referred to a cognitive disorders clinic. And then had a worsening cerebellar syndrome, was hospitalized after falling, no relevant past medical, family or occupational history, relentless deterioration after that point with multi-domain cognitive impairment, expressive dysphasia, myoclonus, visual hallucinations, and examination confirming pyramidal, extrapyramidal, and cerebellar signs of myoclonus. An MR brain here you can see shows basal ganglia diffusion restriction and some cortical ribboning in the left parietal lobe, and EEG was just slow, non-specifically slow, and the CSF RT was positive. And this individual died 297 days after, so 3 times as long as the first one. Still very short duration, but you can see that there's a range here. These are the longer survivors, and postmortem confirmed VV2 sporadic cJD. So in addition to the codon 129 change polymorphism that can influence clinical phenotype, I mentioned that you can have disease-causing mutations in autosomal, resulting in autosomal dominantly inherited Prion disease. And you'll be familiar with these eponymous syndromes, Gerstler-Straussler-Schanker disease, and also fatal familial insomnia. There can be insertions in the Prion protein gene, lots of point mutations that can occur. And on the whole, individuals with inherited cJD tend to have a younger age of onset, a longer disease duration, and a family history of neurodegenerative disease, which might have been mislabeled as something else, Alzheimer's or some other type of neurodegenerative disorder. But that isn't always the case. And I'm just going to present a couple of cases here. So this is an individual who ended up with a diagnosis of D178N inherited Prion disease. And this individual was much younger, 41 years old, and had a history, quite a strong history of neuropsychiatric problems and substance misuse, depression, anxiety, alcohol, and cocaine misuse, and presented with an acute behavioral change after a car crash, and she was thought to be intoxicated. Appeared confused, dysarthric, and had a mild ataxia, and was investigated. And this MR brain scan, you can see here, showed some basal ganglia signal change, some cortical ribboning, but it was in an area of the brain where it was thought to be non-specific changes there. And there was a suggestion from the local clinical team that this might have actually been something related to Wernicke's encephalopathy, and was treated with intravenous vitamin B complex, made some apparent improvement, but then actually things started to deteriorate more relentlessly with more deterioration in behavior, short-term memory problems, and then a very rapid decline with ataxia, some changes, very difficult in frontal behavior, and hallucinations as well. And Prion protein genetic testing demonstrated presence of the D178N mutation. There was no family history of neurodegenerative disease in this context, although there was limited contact with the father. And so family histories can be censored. Clinical presentations can be heterogeneous. Even within families, people can present very differently. And what about the E200K mutations? This is the commonest form of inherited prion disease globally, and can mimic presentations of sporadic CJD. So we tend to see maybe 1 or 2 a year of individuals who are referred as case of sporadic CJD, and after prion protein sequencing are identified to have the E200K mutation. So this case here of a 58-year-old man developed a feeling of dizziness associated with head turning. He had to stop riding his bicycle as a result. He rapidly developed an ataxic gait, needed to lean on furniture, and then started to fall. And his wife noted that his cognition and behavior had changed. He was less interactive, less spontaneous. He had problems working household appliances. His short and long-term memory changed. He had MR sequences that are shown here with basal ganglia signal change, cortical ribboning seen. His CSF 1433 was positive, his S100B was highly elevated, and his RT-QuIC was also positive. And then it transpired on more detailed questioning, which wasn't gained from the local team, that his mother died from CJD 14 years previously, and she had an autopsy and had prion protein sequencing, and it identified the E200K mutation. 2 of his mother's brothers, his maternal uncles, had also died from dementia, but the etiology wasn't identified at that time. This is before she was diagnosed with CJD and had the genetic confirmation. So he'd known about his mother's state, had actually declined predictive testing earlier in life, and he and his wife didn't really volunteer this information about the mother initially. And it then transpired that his wife was actually concerned that this is what it might be and was kind of not really thinking about it. So that can mimic changes seen in sporadic CJD, both in the clinical features and the test results. So it's important to do the prion sequencing. There's some really, this story and the scan results and RT-QuIC would fit for sporadic CJD unless the genotype was done. Now, I mentioned that the unit that I work in here was really established in 1990 for surveillance, which is exactly what it says on the tin, to see if there are changes in the way that people with CJD are presenting. And my predecessors here in the mid-1990s identified a new presentation of individuals with CJD. And these individuals were younger and presented with unusual, more predominant neuropsychiatric features and pain and ataxia. And these are the things that seemed unusual. So the first case of variant CJD was reported in 1996. The majority of cases that have been reported have been in the UK. I mentioned that the molecular evidence now, but there are other forms of evidence as well that suggest that this is really causally linked to BSC in cattle and humans, primary transmission. And the timing and emergence of variant CJD and BSC and the geographical distribution strongly suggests this, but also, as I mentioned, the molecular strain typing. There have been now cases of secondary transmission reported via blood and blood products, and recently also after a laboratory exposure in France. So this created a huge amount of governmental and media interest in the late 1980s and early 1990s. And there was a real concern about what had been done in terms of practices that had led to BSC in cattle and what might be happening in the UK population. And I mentioned these individuals particularly were causing concern because they were younger, had a slower progression, a longer disease duration, often presented to psychiatrists with depression, delusions, hallucinations, had quite painful sensory symptoms in the limbs due to thalamic central pain, and had other neurological features, including career-form movements and dystonia. And in the later stages would then look like other forms of CJD with motor features, myoclonus, and immobility. And the diagnostic criteria for variant CJD really encompass these things: a longer disease duration, routine investigations don't suggest an alternative diagnosis, no evidence of genetic CJD, no history of iatrogenic exposure, and then really focusing on these early psychiatric symptoms, painful sensory symptoms, ataxia, myoclonus, and dystonia, followed by dementia. And these individuals had also a characteristic change on MR imaging, which is high signal in the thalamus posteriorly, so the so-called pulvinar sign seen here. One of the other things that differentiates between this form of CJD and others is that the tissue distribution is much wider. So in sporadic CJD, tissue distribution is really limited to the central nervous system, whereas in variant CJD, all lymphoreticular tissues have now been identified to have in variant CJD present, and this can lead to a diagnostic test called a tonsil biopsy, which can be done and demonstrates positivity in these individuals. So again, there's a hierarchy of classification from possible to definite, and definite is really autopsy confirmed. And I mentioned before, the glycotype here is very different to the glycotype seen in other forms of disease and resembles that seen in BSC. So the median age of onset in cases in the UK was in the late 20s, and the range, we've seen some pediatric cases, thankfully not for a very long time now. And the older individuals, this one here at 74 was actually a blood transfusion recipient. I'll come on to talk about that later. The range of duration was really 6 to 114 months, so much longer disease duration, averaging 14 months. And the majority of individuals are all homozygous for methionine at codon 129, but the last UK case was methionine valent heterozygous, which raises a concern about future cases presenting atypically, certainly compared to this clinical phenotype, in older adults who are methionine valent heterozygote or valent homozygote. And I mentioned the tissue infectivity is very different. So in sporadic CJD, really linked to brain and spinal cord, there are public health risks if there have been recent eye surgery, other spinal surgeries. But in variant CJD, the infectivity affects all lymphoreticular tissue. So if these individuals have had surgery, donated blood, there is a risk of transmission. And this really reflects what we think is the peripheral pathogenesis from GI tract to brain. So this chart just summarizes the cases worldwide, and you can see here there have been cases identified globally. This chart is not quite up to date because there have been now cases identified more recently in France related to occupational exposure. The last UK case was this one here, 2016. And thankfully, this trajectory of change really resembles what we've seen with BSC, in that there's been a sharp decline, but the concern is that there might be further peaks with emergence of cases in MV heterozygotes or valent homozygotes. So what about secondary transmission of CJD in general? I've alluded to this. So this has occurred already globally in individuals following corneal transplants, depth electrodes for EEGs, neurosurgical instruments that are contaminated, the practice of deriving growth hormone from cadaveric growth hormone, cadaveric dura mater as well, and these sad cases of variant CJD that have been transmitted from blood. So here you can just see the number of individuals that have been reported with growth hormone related CJD, the majority in the France, UK and US. Prominent clinical signs are cerebellar in these individuals, and then the cognitive and excuse me, other features. And the average incubation period is 17 years from when they received the growth hormone, subcutaneous growth hormone, but there are individuals who have been developing symptoms 4 decades after their growth hormone treatment. And then I mentioned these other routes of transmission and cases that have been described. And again, the prominent clinical features tend to be cerebellar with a longer disease duration, incubation period, and then disease duration. These 4 cases of variant CJD have been reported in the literature. Really, these are from individuals who received blood, red cells, that were donated from individuals who went on to develop variant CJD. One of these individuals diagnosed for a non-neurological disorder, but it was identified at autopsy in the spleen that they had variant CJD in the spleen, but not the clinical syndrome of variant CJD. But these other cases, and I mentioned one of these, the 74-year-old, was someone who developed variant CJD many months after, many years after receiving the blood. So these are sad cases, but also demonstrated this scientific plausibility that whole blood can transmit variant CJD. The practices have changed now, so blood is leukodepleted as a result. So just to move on now to how we manage these symptoms, they're obviously devastating disorders, rapidly progressing, lead to significant disability in a rapid way, and have a lot of stigma. But people talk about human BSE, mad cow disease, neuropsychiatric symptoms are common, dementia is common, family members left in shock while the diagnosis is being worked up, and there's a profound bereavement reaction for families. Now, there are pragmatic, non-pharmacological approaches that are summarized here for a number of symptoms that people might have, and these really reflect the sorts of interventions that you might have for individuals with advanced dementias. There are also pharmacological approaches for managing delirium and agitation. Atypical antipsychotics are often required. Benzodiazepines work effectively and can be given subcutaneously and intravenously. Myoclonus is a problematic symptom. Often it's more distressing for family members or staff watching the individual. It's difficult to know how much they're suffering, but actually many individuals are treated with anticonvulsants, clobazam, clonazepam, levetiracetam, sodium valproate. All of these can help with calming down the intensity and frequency of myoclonus. Other symptoms can be common, particularly in individuals who are longer survivors. Visual hallucinations, for example. There's some evidence now that cholinesterase inhibitors can help with this. And then other features that are common to other more advanced neurodegenerative disorders like hypersalivation and speech problems. We tend not to, in the UK, so much implement invasive measures like gastrostomy and non-invasive ventilation support, but in many countries, for example in Japan, these are instigated more frequently. So we can't get away in the current climate without talking about how COVID has impacted on things, and certainly in the United Kingdom, case ascertainment we've managed to keep up partly via the use of this sort of video conferencing type of assessment of individuals, but there have been restrictions then in how much information we can gather from families in a timely way. There have been impacts on RT-QuIC. There's a theoretical risk of individuals who are COVID positive having a CSF RT-QuIC assay that the people don't really fully understand if that's a safe thing to be doing, so often wait until RT-QuIC, they're COVID negative before running the RT-QuIC. So there have been some diagnostic delays. But on the whole, business has continued as usual, and we're now kind of opening up society, so visits are occurring again. Just in the last section of the talk, is there a need for ongoing clinical surveillance? I mentioned that there's a tail off in the number of cases of variant CJD seen globally. Well, I mentioned that the need for ongoing surveillance is really to consider if there'll be any more primary cases related to individuals who are methionine valine heterozygote or valine homozygote at codon 129. There is a risk of secondary transmission. I've highlighted there have been cases related to blood, but there's also a risk of surgery and other occupational exposures. I'll just touch on briefly emergence of new animal prion diseases which raise concerns. So what is the prevalence of the primary variant CJD infection in the UK population? We know in the UK that BSC was a huge population, a huge epidemic amongst cattle, and we know that the number of individuals who must have been exposed through diet was enormous. There have been a number of attempts to study the prevalence of latent infection, subclinical infection, by looking at appendicectomy and tonsillectomy tissue from individuals who had these procedures for other reasons. We don't know anything about their clinical state other than they were really asymptomatic, we assume. And what's happened here is that individuals have been identified with positive variant CJD immunohistochemistry in the appendix and the tonsil in individuals. And these are a series that have looked at individuals that were born at different cohorts, really. And this has left a number of unanswered questions about the potential extension period. Is there going to be a more extended period of human BSC exposure than we thought in the early 2000s? And will this mean there are cases diagnosed later? So that's raised concerns. And another concern that was raised was after the report in the New England Journal in 2020 from France of an individual who developed variant CJD after lab exposure. This is a very sad case of an individual who was 24 years old in 2010 when she was working in a Prion research laboratory in France, and she was handling frozen sections of brain of transgenic mice that overexpressed the human Prion protein. And these mice had been infected with sheep-adapted form of BSE. And during the process, she stabbed her thumb through a double pair of latex gloves with the sharp end of curved forceps. And 7 years later, she began to have the typical syndrome of variant CJD with burning pain in her right shoulder and neck, pain that spread through her body. She then developed an ataxic syndrome and cognitive impairment, and her investigation results, including MR brain, were supportive of variant CJD, and unfortunately after that an autopsy confirmed this as well. So this is her, and this raised a huge amount of concern in France, and since that time there's been a second case of an individual who had a laboratory exposure who's now developed variant CJD and has deceased, and did not have an autopsy, but the clinical features and test results in life confirmed probable variant CJD. So this has raised concerns, but it might be a more nuanced group. These are lab workers who are exposed to highly infectious materials. It's not kind of the main way in which individuals may develop disease. What about other zoonotic threats? Well, chronic wasting disease is something you'll have heard of in the States. It's a prion disease of free-ranging and farmed cervids, and has been labeled as zombie deer disease. It's spreading like wildfire throughout North America and in Scandinavia. And in deer and elk with this condition, the infectious form of prion protein can be found in many extraneural tissues and body fluids and in excretions from these animals. It can affect elk, deer, white-tailed deer, moose, reindeer, so a wide range of cervids. And as I mentioned, geographical spread has been throughout many of the states in the middle of the states, and then now also in Norway, Finland, Sweden. So this has raised concerns about the possibility of transmission to humans. Chronic wasting disease in reindeer and moose, you can see they have changes of vacuolosis, spongiosis on autopsy. There are characteristic changes on Western blots. And there are suggestions that the types of chronic wasting disease differ pathologically and biochemically between reindeer in Scandinavia and North American CWD. So there have been some epidemiological studies. There's ongoing surveillance in the States and Canada. So far, there's been no observed correlation between CWD exposure and human prion diseases. And so far, studies have been restricted to large population-based cohorts and small case series, but there have been no cases reported. Animal and in vitro experimental studies suggest that it's actually quite hard to transmit CWD, so there's a species barrier, and so there's a theoretical risk that this being transmitted to humans is actually low risk, but we can't exclude the possibility. There are ongoing concerns though, because the transmission might follow long, may need long incubation periods, and clinical features might be indistinguishable from typical sporadic CJD. What about other zoonotic threats? Well, in North Africa, Italian and Algerian researchers have now identified a camel prion disease affecting camel and dromedary. And obviously that has implications because camels are used ubiquitously across the world, and also in diets in some places are eaten. And what I wanted to do just at the end is touch on the urgent need for potential therapies for these disorders. So I touched on symptomatic treatments earlier, but there have been very few well-designed randomized controlled trials for treatment of these disorders, and most reports have been anecdotal or small case series. There have been some clinical trials. There's an antimalarial drug called quinacrine that's been studied in London and in San Francisco, and this was following some encouraging results in a cell model, but unfortunately no effect in a mouse model, and 2 clinical trials have showed no survival benefit in patients. Pentosan polysulfate is something that was given intraventrically to individuals with sporadic CJD. There were complications of neurosurgery. There was no real effect on disease progression or survival. Tetracyclines have been looked at, The most recent treatment that's been reported in the last few weeks was an anti-PRP monoclonal antibody. So we know that PRP in its host encoded state is required for conversion to the abnormal malformed state. And if a monoclonal antibody can target PRP-C, perhaps this could work. It was a study of 6 individuals and it was reported to be safe, and it's really too small a study to report on functioning and survival. So the formal efficacy trial has been proposed and is pending. But really what this points to is that whilst the biology is interesting, very interesting, there haven't been really key advances in therapeutics, and there's an urgent need for larger, particularly because of the rarity of disease, multi-centers, multinational RCTs for all types of prion disease. Right, so that was my whistle-stop tour. Just to summarize, human prion diseases are characterized really by rapidly progressive cognitive decline, neuropsychiatric features, and motor features. And there's a constellation of these that can lead to diagnostic classification. The commonest form of disease is sporadic. 10 to 15% of people can have autosomal forms, and acquired forms are important as well. And the survival of the commonest form is only 4 months. It's very rapidly progressive. I wanted you to understand that MR brain and RT-QuIC are the highly sensitive and specific investigations that we would employ now. There are ongoing concerns about variant CJD and the emergence of new prion diseases, which are worth bearing in mind. Non-pharmacological and pharmacal management is challenging, but there are treatment options. And finally, the need for trials. So thank you very much for your time. I'll stop there. I just want to thank really all of the individuals with CJD and their families. It really is a devastating disease. Clinicians that we've worked with across the UK. And if anyone would like to contact me after this, or I've got my details down here. Thank you very much.
Thank you so much, Dr. Paul. That was an amazing lecture. So I think we're gonna open. We had like a good time for questions and answers. Anyone that wants to talk in the microphone, just feel free to just ask questions. Oh, you can, oh yeah, I can see Dr. Spar make a questions in the chat. I can start with this one. Are there still cases of Kuru in New Guinea, or has it been controlled?
So Kuru is an interesting one. So Kuru is a form of acquired human prion disease from endocannibalism. I'm not familiar with the most up-to-date research on that, but the number of cases were very high several decades ago, and the practice of endocannibalism has stopped. But I think there is a surveillance program out there still looking to see if individuals are developing this, and particularly some of the information from Kuru cases has been very interesting, in that that's where we understand that individuals who are methionine, valine heterozygote, and valine homozygotes at codon 129 of the Prion Protein gene to have longer incubation periods. So there is still a theoretical risk that individuals who are VV or MV might develop disease, but I'm not familiar with the most up-to-date information there.
Okay, there is another question. Dr. Wong, do you want to ask a question?
Yeah, hi, Tony Wano here. Excellent talk. Thanks for the information, very helpful. What's the current guidelines for the instrumentation, such as spinal fluid, spinal needles, and surgical instruments before the diagnosis is made? And what is the transmission analysis for those kind of peripheral instrumentations? I think that one of those questions are on the chat group as well.
Yeah, great. So the risk really relates to the tissue infectivity, and there have been some tissue distribution studies and the type of CJD. So in sporadic CJD, I mentioned that the risk of neurosurgery, brain, spinal cord, spinal ganglia, pituitary gland, that's all high. And if an individual, certainly in the UK, has had this sort of surgery, the instruments are quarantined, destroyed. You can't clear the infected prion agent. Spinal here, I mean, we use disposable spinal tap needles, and there's no over and above usual infection control procedures for doing a spinal tap. We don't recommend anything over and above usual infection control procedures that should be taken. When there were cases of variant CJD that were more ubiquitous, if people were having scopes, for example, endoscopies for upper GI, lower GI, they would have to be quarantined as well. Again, you can't decontaminate these instruments. So there are infection control guidelines that are really bespoke to local areas. So I'm not familiar with what you guys have in the States, but certainly there will be, based on these tissue infectivity, high, medium, and low risk tissues, and decisions and protocols based on that, really. And the two things to consider: the type of CJD and exactly the type of operation that occurred. Was it lymphoreticular? Was it central nervous system? And there have been epidemiological studies looking at the basic risks of surgical transmission in individuals with sporadic CJD, for example, and the risk is thought to be actually very low in non-CNS tissues.
Okay, there is another question coming from the chat. Is do we know how transmissions through EEG electrodes takes place?
Oh, so these were depth electrodes, not the standard scalp electrodes. These were like intracerebral depth electrodes. Yeah.
Okay. Okay. And also from the chat, do you know if they screen prior before blood transfusion?
So there is no screening test in blood for prion disease, and that's been a major research effort for a number of groups to try and, for obvious reasons, be able to screen, but at the moment there's no sensitive or specific blood-based assay for CJD which transfusion services can use. Okay.
Also from Dr. Boswell, is there any data of pediatric involvement?
So there have been 6 cases of individuals with variant CJD under the age of 18, and there are individuals who have been reported in the pediatric age range with sporadic CJD, but it's highly unusual to develop sporadic CJD under the age of 20, but there have been isolated cases reported. And if there are individuals who are developing CJD in the pediatric population, we would have significant concern about an atypical form of prion disease, variant CJD, or inherited prion disease before making that diagnosis of sporadic CJD. But it has been reported in individuals as young as 15 in sporadic CJD.
Okay, I got it. Dr. Litton is asking, is there any drug or pharmaceutical compound that has been used to disrupt the protein?
To destroy the protein?
Disrupt,
Yeah, no, there haven't unfortunately been any compounds that can clear the protein from the nervous system or decontaminate. I mentioned the trials that have looked at these are the quinacrine, pentosan, tetracyclines, and PRN 100, but there is an urgent unmet need for that area, really, either blocking the PRPC to PRPSC transmission or clearance of PRPSC. Yeah.
Okay. Okay, there's a question from one of our residents. Does prion protein become non-infectious if beef is overcooked?
No, there's no evidence that it's heat resistant, unfortunately. So the cooking practices, I don't think, really affected how it was transmitted. Yeah.
Okay. Okay, there's another question from the chat. Is regarding the environmental exposure, other than animal, is there any hazardous material involved?
From environmental exposure, no. So I know in other neurodegenerative disorders, there are environmental factors that might contribute. That certainly hasn't been identified in sporadic CJD. It's either thought to be a stochastic change in the prion protein gene or something that occurs later in life. As with other forms of sporadic neurodegenerative disease, we don't know is the honest answer why people develop this disorder. and what initiates the change in their 60s, having led a normal life up until that point, and also what leads to a tail off in the incidence in people's 70s and 80s. Is it under ascertainment of cases, or what's really happening? But there is no real strong evidence from environmental based research to suggest any environmental risk factors.
There is a question for one of our attendees, Dr. Wong. Is there a role of genetic testing for the different variants of the MV or VV status, not for patients, but for researchers or medical personnel?
In a clinical context, you mean, for people who have CJD, or?
No, I think it's more for the people that are involved in like medical personnel or researchers that are trying to work with the Prion disease.
Oh, to understand their own risks of CJD. Yeah, I mean, I don't know how satisfactory that would be. I mean, so if you understood your codon 129 status was MM, I don't know how you would risk stratify. You would clearly be at higher risk than somebody who was MV or VV in terms of disease duration or incubation period. But I don't think that's really a satisfactory way of screening risk, to be honest.
Okay, let's see if there's any more questions. I'll also remind anyone in the audience can just also feel free to open the microphone if they want.
Yeah, this is Nick Palmitsakis. Thank you, Dr. Pal, for the very comprehensive lecture. I have a question regarding prion and other neurodegenerative disease, because I think Prusiner, Stanley Prusiner, I mean, has this theory that Parkinson's or Alzheimer's are also relate to prion disease. What is the current, let's say, research, or what do you think the best, let's say, current opinions are on this subject?
Yes, so I agree with you that there are certain leaders in the field who would propose that protein misfolding disorders of any form have a theoretical risk of transmissibility in a prion-like mechanism. I think for public health purposes and the sort of things we mentioned in terms of risk of transmission via surgery or transmission from person to person or dietary spread, I don't think there's sufficient evidence to say that anything like that is occurring, although there are epidemiological studies that are looking at risk of Alzheimer's following surgery and that sort of thing. But it does offer an entry point perhaps into therapeutics, that if there are treatments for protein aggregation, protein misfolding disorders, protein to protein spread that can occur in one, these might be templated across different disorders. But certainly it's an area of active laboratory research. I don't think that it has translated into the clinical field really in that strong a way.
Okay, thank you.
Let's see if there's any more questions. There is no more questions. Just want to take again, and thanks again to Dr. Paul for this presentation. It was very important for us, and thank you for all the time that you took to give us this lecture. I just posted something in the chat for everyone that we're trying to make this available for you to review later or to share to any of your colleagues. That's about it, Dr. Paul.
Yeah, brilliant. Thank you very much for the invite. It was very nice to meet you all. And as I say, please do contact if any additional questions come up. Thank you very much.
Definitely. Thank you so much.
Thank you, Sergio. Thank you. Thanks, everyone.
Okay. Thank you to the audience as well.